Welcome, Denny Lamb, CEO of Process Record Slide Limited. I'm really looking forward to chatting with you today about the concerns you have over quality control of immunohistochemical staining in particular. So I think a great place to begin is outlining the broad problem that you've basically brought to the table.
Thank you, Rich. I'm the founder of the PRS, Process Record Slide Limited. I invested into this project since 2018 with two engineers who used to work for a CAP project in Toronto. At that time, CAP initiated the project because they found that the IXC staining has not been stable for many, many years. They would like to develop an audit slide or standardized slides that, to standardize IXC staining results. So after 5-6 years that we come out the product, our product is now CE IVDR registered, and we were also registered as a FDA Class 2 surrogate calibrator. Since last year, after the pandemic, we tried to advocate the using of PRS to replace tissue control. We've been facing a lot of obstacles because the methodology is pretty new. A lot of histology lab or pathologist lab, they are so relying on a tissue control for their daily routine. Yeah. And in the beginning, we have not many ways to convince the people, and now we believe that we have a final pitch. We found out that the traditional tissue control is kind of like not legitimate in the IXC staining, yeah. And I would say that it is actually not right method at all. Yeah. But people are still keep using it.
Yeah, you've brought a prop there.
Yes.
Looks like a test that we all know all too well. What's the relevance of this lateral flow assay that you've brought along? Okay,
so I brought the COVID test kit. Actually, thanks for the pandemic to bring me the inspiration, how it correlated to the PRS.
Right.
When I think that everyone knows that every single COVID test kit, they got a C and a T, yeah. And then if you got if you confirm that you got a COVID, you have to have a C line and a T line expressed. Yeah. Okay, so the C line stands for the control, and the T line stands for the test or positive, whatever. So in IXC staining, the industry accepts that we can only have a batch control, or we can only use one batch control for a month, or for a week, or for every day, or for any specific antibodies. Right. However, when we look at the COVID test kit, it is mandatory that every single test kit, you need to have a control. Right. Otherwise, no one will accept it. Yeah. So that the industry has already had a guideline that every single test, you got to have a control. Right. And this control or this specific device is actually classified as a class 3 device. And most of the staining platforms are only class 1. Right. And then without the batch control for cancer diagnosis. Right. And this is why that, we bring me that to the issue that, a lot of the pathologist lab or histologist lab, if they only rely on a non-standardized, non-categorized tissue control to validate IXC staining for the pathologist to carry out their cancer diagnosis, I think that this is not proper. Right. Yes, especially if the pathologist happens to misdiagnose because of the staining error.
So it sounds like you're questioning, even debunking what is a very common process right now. So why do so many esteemed, organizations, associations, authorities rely on this, what seems to be an outmoded method? And what evidence, you mentioned the evidence studies. Can you share a little bit more detail about the evidence that you've come across?
Well, there are quite numbers of the papers and studies about the immunohistochemical staining errors, I think since for the last 20 years. But just recently, I can bring out the one that from Ohio State Universities in 2016. I think they have done about like 400 immunohistochemical staining on the major staining platforms. And I think that they have found that the error can be from 13 to 36%. Right. And the other one is in 2019. I think the paper was from the University of Toronto. They have done over like 20,000 slides studies, and they found that the percentage of error can be from 0.8% to 9%. And then they conclude that every single IXC staining requires an on-slide tissue control as a conclusion. I think the conclusion was not new to the industry, because no matter QC, College of American Pathologists, even for the QC department in UK, I think that they actually recommend the people using tissue control on each slide when they do the staining. But historically or traditionally, that histology lab or pathologist lab, that they rely on the batch control, and sometimes because they think that it is almost like impossible or difficult that to do each slide with a tissue control.
Yep. So you've highlighted the main issue, and it seems like quite a big one. And you also hinted at a potential solution. Obviously, this process record slide technology was developed and has been further developed by your company. Can you tell us a bit about what you recommend? How do we improve the quality control process? Our slide is created for every single IXC staining use. Because one slide, we can do almost all IXC staining with the specific antibodies. Because control material, control slides itself, that we should not tell you the specificity. I understand that a lot of people, they would like to have a control slides for PD-L1 or HER2, for those very insensitive primary antibodies use. However, if we make such a specific control slide for that applications, the slide has to be classified as a class 3, because that we need to reconfirm the specificity of the primary antibodies applied. Right. So the same will also apply that to the tissue control. So the tissue control, if it is for the reconfirmation of the specificity during the IXC process, I'm sorry to say that pathologists or histologists relying on a non-standardized, non-categorized tissue control as a class 3 medical device, which is seriously violating the conduct of running a clinical laboratories. Right. Yes. Big problem.
Yes. So that is why that we keep our slide as a class 1 medical device with the non-specific primary antibodies target and the non-specific primary antigen, secondary antigen target, so that we only need to show that the efficacies of the primary and the secondary levels, instead of showing the color itself. Right. But the key things is we need to know the efficacies of the primary antibodies capture and the secondary antibodies capture. Yeah. So if we provide a gradient of the secondary antigen target and the primary antigen target, so if we don't see any, if we see any dot missing, that means that the efficacy is not good. Right. So it is an evidence-based quality indicator instead of just showing you the color of the final results.
Right, fantastic.
Yes.
Well, thank you so much, Denny Lam. It's been a pleasure talking to you and exploring this problem and the potential solution. So thank you for joining us.
Thank you. Thank you very much for the time, Rich.